Hello and welcome to our inaugural Project ECHO Infection Control COVID-19 series. We are so glad you have joined us, and I wanted to go over a couple of housekeeping tips. To unmute and mute yourself if you'd like to ask a question or provide a comment. The easy way to do so is to hold the space bar to unmute yourself and then release it to mute. If you are joining us by phone and using the audio only feature on the phone, press *6 to unmute yourself and then *6 to mute yourself. We would love to see your smiling faces, and I'm so happy to see a lot of them. So if you can, please share your camera. This helps us create a sense of community. Also, there are so many of us that we cannot go through and introduce everybody, although we would have loved to do that. So please enter your name and organization and email if you can in the chat window. You can also provide questions and comments in the chat window. If ever we are not able to reply to your questions or comments during the session, we will email the responses after the session. Just a little reminder, in any of our sessions, no PHI should be mentioned or shown. Any names are fictitious in our sessions. If you would like to ask a question, you can raise your hand. Again, on your phone, you can do *9, or on the computer, if you're on a Mac, it will be Option Y. If you're on a PC, Alt Y. You can also ask the question in chat or by muting and unmuting yourselves. I am, again, so grateful to be part of this infection control COVID-19 series, and I will pass this off to Delanor for a warm welcome from the Kentucky Nurses Association. Delanor?
Hello. Welcome to the Kentucky Nurses Association, University of Louisville on nurses in COVID-19. My name is Delanor Manson. I'm the CEO of the Kentucky Nurses Association, Kentucky Nurses Fashion Coalition. This morning for this incredible discuss infection control issues and opportunities. We have people here with us today. In this year of the nurse, I would be remiss if I didn't reference Florence Nightingale as an early adopter of epidemiology as a role nurses should assume to improve health and to save lives. I am sure she would be proud of this session and the future sessions because she knew of the importance of education focused on nurses with the intent to protect and do their best work in the world. KNA will be working with the University of Louisville to provide and enhance today's session and future so to the KNA website. Again, welcome.
How about this? Is this better?
Much better. Thank you.
Thank you. Thank you. It's amazing. My husband tells me there is no mute button big enough. I have to tell him that actually there is. So thank you for your words. I know we will be challenged with all of our connections, but we're going to be muddling right along, and we're trying to figure out how do we make technology work every day. How we make it work in the midst of a pandemic is yet another challenge. So thank you, Kim, for the introduction. I also want to take a minute and ask Andrea Flincham if we can get a voice from our State Department for Public Health. We are so grateful to have Andrea join us, and I know she's in heavy demand. So even if you are in and out, Andrea, thank you for being here, and I'd like for everybody to hear your voice.
Well, thanks, Ruth. I will make my apologies for not having a camera, but, you know, I've had no cut and no color for 10 weeks, and I'm not fit to be seen in public. So there you have it. My children are calling me Aunt B right now. So my name is Andrea Flincham, and I'm the manager of the Healthcare Associated Infection Antibiotic Resistance Prevention Program here at the Kentucky Department for Public Health, or KDPH. So say hello this morning, and I'm also very thrilled at the collaboration this pandemic has brought on. If there can be anything good that has come from it, then this is it. Never in my memory in being in have I seen such a collaboration between public health association and to be so closely tied to one another. I know today that you all are going to be reviewing the KDP guidance. I'm glad that you have the opportunity to see that. I will say post-COVID will be a post-COVID-19 era. I want these ties to remain. Will enable us to provide better and safer care to all of our patients and residents regardless of the setting. I'm going to turn this over to the.
Thank you very much. Thank you very much. If you the participants will let me know, it looks like that we have trouble maintaining then stable connections. I don't know if it's because of the numbers of us or just since everybody is working virtually now. But if at any point you lose connection or we have a problem, please let me know in the chat, or you can always hit your raise your hand button on Echo and alert us to any issues. Otherwise, we think everything is going well and we'll continue on. Before I get started, I also want to introduce then the other two presenters that are with me today. First of all, my name is Dr. Ruth Carrico from the Division of Infectious Diseases. I've spent a majority of my career in the infection prevention and control realm. So I just have to say there's nothing like working in infection control in the middle of a pandemic that changes your life. And I'm happy to have this opportunity to connect with a number of colleagues, both previously in the present and in the future. So if I could, Dawn, I'd like Dr. Dawn Balcom, if you could introduce yourself, and then we'll move to Montre Smith before we get started.
Well, hi everyone, and thank you so much for joining us today. I'm Dawn Balcom. I'm a family nurse practitioner. I spent the majority of my career in the emergency department. I've worked here with Ruth in infectious diseases for the last almost 9 years now.
Hello, everyone. My name is Montre Smith. I am an assistant professor with the University of Louisville School of Nursing. My background is that I am a federal national disaster member, and I had the privilege of working about cases, and I was invited to our series today. So again, thank you so much. Thank you so much.
Thanks, Ruth, and let's get started. Our focus today is on nurses and COVID-19. This, of course, is very near and dear to all of our hearts because we know the key to being able to provide a stability within a community is ensuring that we have the healthcare workforce and the healthcare infrastructure protected. As the profession that will touch every citizen, every individual at some point in their lives, nurses are, from my perspective, the most important healthcare provider as we are addressing what is going on with the pandemic, because nurses will be touching up close, providing care, sometimes very intimate care to our patients, and therefore every focus needs to be on the safety of our nursing personnel. So today we're going to spend some time talking about exposure, what is involved in returning to work, and because there is so much going on with immunity testing and questions, I want to end our session focusing on what we currently know and what we don't know but need to know. Our objectives today are talking about healthcare worker exposure and its management. We'll talk about strategies that impact nurses' ability to safely return to work. And again, I'm grateful to Andrea and the work that's been done by the Kentucky Department of Public Health in outlining then some guidance that has been well distilled and I think provide us with our excellent launching pad for how we can develop policy and implementation. We will end then by talking about some of the current testing methods. We'll specifically address some of the strengths and weaknesses and how this is important for nurses to understand because we may act on some of that testing result, and we need to make sure that both as nurses, we understand what that means, but equally as important, those that may be in leadership roles, so that you can make sure that information is adequately interpreted for your personnel. So let's jump right in and find out a little bit about the speakers. We have no disclosures to declare. Our sole objective is improving the knowledge of nurses and other healthcare personnel and providers surrounding infection control. We want to focus today on nurses in all settings, regardless of whether you are at the bedside, in academia, or in any place where healthcare is delivered, and then other healthcare workers that may be involved in the exposure issues with this pandemic. All right, our next thing. I love this quote, Louis Pasteur, "The microbe is nothing, the terrain is everything." And I think that sets the stage for us, and how are we providing care and what needs to be well understood in our care environment so that we can safely do this. So I want to look at then what we know about healthcare workers and disease. And this will really kind of level set and set the stage for our discussion today. Many of you, I'm sure, saw this that came out from Wuhan. Our colleagues in China then described a case series, 138 hospitalized patients with this novel coronavirus. And this was made available to us in February. This described 138 hospitalized patients. There was a presumed person-to-person transmission in 41%. And of those, we found that 40% involved healthcare personnel who were ill, 29% of this group. And if you look at then where these individuals, where these healthcare workers provided care, a large proportion on the general wards, a smaller proportion in emergency departments, and then even a smaller portion in the ICU. But I don't want you to think that that the risk is any less in the intensive care unit. This just happened to be where these individuals worked as part of this case series. So this was our first information that Houston, we have a problem. This was from California, where we saw essentially the same bit of information, that healthcare personnel experienced exposure to this novel virus when they are providing care for patients. And this happened to be another review of what happened in the hospital setting. 121 hospital healthcare personnel were exposed to patients with COVID-19. 35% of them developed symptoms within 14 days of exposure. And the patient interactions that were linked back to these exposure events included the physical care, both physical examination of patients and just the physical contact, up close, listening to lungs and so forth, but also during the performance of specific treatments. In this case, descriptions of nebulized respiratory treatments. So it reinforced the notion of the aerosolization of these particles. So the problem we saw in California was very similar to what we saw in the United States. So this was not just an issue to Wuhan, now it's an issue in the US. Our next example was more recent, and this involved long-term care facilities. This was a report from a long-term care facility in Washington. The middle of March, 167 confirmed cases affecting 100 residents, 50 healthcare personnel, and then an additional 16 visitors found to be epidemiologically linked. Most, but not all, have respiratory symptoms consistent with COVID-19, but it's important to recognize that 7 residents that were infected, there were no symptoms documented when they did the review of their electronic health record, their medical records. So that then reinforced our concern about the asymptomatic individual, someone that may be ill but not have symptoms, nevertheless they are infectious to others. Among those that were ill, hospitalization rates were over 50% in the facility residents, 50% in the visitors, and 6% in the staff. And unfortunately, in this at-risk group, we had a case fatality rate of almost 34%. So when we think about the importance of nursing and where our role is and what our responsibility is, again, remember, it is clearly our responsibility to do no harm. unfortunately, the care for the residents at a period of time when we were not recognizing how transmission could occur, how transmission can occur among those that are asymptomatic, what the role is of visitors or individuals coming in and out. A lot of this was learned by the willingness of this group to say, these are our experiences and this is what we need to share so we can all learn from that. As of March 18th, we've had a total, at least at the time of that publication, which was the end of March, so just 10 days later, a total of 30 long-term care facilities had at least one confirmed case in King County in Washington. So they were very fast-moving and very forward-thinking in providing information about what was happening in long-term care. So now we have been two major areas of clinical practice for nurses where physical care and close involvement with patients is present. And in both of these settings, we saw then nurses becoming ill as part of their job responsibilities. Now, having said that, I know many people will say, well, we don't know whether illness and exposure occurred in the community or as part of their work. But I think the important point to recognize is that our testing emphasis needs to be where the illness is occurring. Many of us that studied epidemiology know the story of Willie Sutton, the bank robber, and when somebody said, Willie, why did you rob banks? And he said, well, that's where the money is. And I think that approach is very similar to today. Why do we need to be monitoring patients and healthcare workers in healthcare settings? It's because that's where the disease is. And so ensuring that healthcare personnel are safe, are protected is vital if we are to be there for addressing the needs of the future. And it's important to remember that patients are going to continue to come to healthcare settings with illness that may not be COVID related. We're still going to have pregnancy, and we're still going to have MIs, and we're still going to have people working to control diabetes and so forth. So these are not necessarily COVID induced or COVID related illnesses, although they certainly can be. But my point is that patients are going to still come to the hospital and to long-term care facilities, and therefore we must maintain a healthy workforce. All right, our next slide. As a reminder about this illness, and again, just to again frame this slide, remember that now we have a virus to which we have a relatively no immunity. Even if everyone who had been identified as positive, if we were to assume that they had immunity, and we know that that is likely to be incorrect. But if so, we have only experienced or have a documentation of illness in a 1 to 2% of the entire U.S. population. So we have really got to keep an eye on and understand how this disease is transmitted. So this is a respiratory pathogen, or primarily lives in the respiratory tract when the individual is infected, although it can certainly be found in other body fluids. But the organism, the virus, can be projected when the individual laughs, hums, talks, sings, as we have heard about the outbreaks associated with singing in choirs. Some of those particles will be heavier and drop out of circulation, but many may continue to stay afloat in the air for some period of time. It may be a very short period of time, and those that are not as heavy then as the original particles that dropped out of the air, as is shown by the arrows. Others may stay afloat for a little bit of distance and then will settle onto environmental surfaces, and then others may stay afloat in the air and be able to land a little bit further away from the individual. This very particle size creates issues for us when we're thinking about personal protective equipment in all situations. This is why we will have standards that will say certain types of PPE are to be used around patients known or suspected with COVID-19, because there are still many unknowns. We know disinfection of the environment is important because those are the surfaces that you touch as a healthcare worker. You then touch that surface, touch the patient, touch other items, even adjust your own respiratory equipment or rub your own eye. Then you auto-inoculate so that environmental contamination can directly touch you. I read an article not too long ago. We were talking in the office about how many times a day does an individual touch their face? And the article that I reviewed a couple of years ago, looking at this from an engineering perspective, said that in their studies, individuals touch their face an average of 18 times an hour. So some of us, I know, touch our faces a lot more. Some of us have our finger in our nose, maybe more than others, but we have the opportunity then to transmit that organism from surfaces to ourselves. We also know that there are issues involving personal illness. This is why we want to social distance, why we want to stay at least 6 feet apart. This is why if you are ill or are concerned about your health, we need you to isolate until you have a better idea of what is happening. And this recognition of the asymptomatic carrier has then prompted the notion of source control or universal masking. As we talk throughout our series today, we'll use then two terms. One is the actual virus, that is the SARS-CoV-2 virus, and when we talk about the disease, then we use the term COVID-19. So our challenges are recognizing that we can have an infectious status in patients or residents who are asymptomatic or those that present in an uncharacteristic way. We're finding in presentations, we've all been reading about the children that are presenting with this autoimmune, this inflammatory process, and then found to be infected with COVID-19. So everything we have thought about regarding infectious diseases has really been turned upside down because we have many new aspects of the infection that we identify every day. We also seem to have a lack of universal approaches to protection. That means we are using isolation, PPE, and universal masking in different ways throughout healthcare settings. This makes it very difficult to support and to train and to expect then standardized approaches to protection. This is not necessarily that this is a bad thing, it's just a challenge when we're trying to address COVID-19. The problems are that we have inconsistencies within a healthcare setting and across healthcare settings. So it makes it very hard for us to train and then identify process and practice deviation. But at the end of the day, even when we feel like we do everything right, we can still have failure in our protection. So not every piece of personal protective equipment, even if it's used correctly, will protect anyone 100% of the time, because we all have these differences in how we touch, how we adjust, the types of PPE that we put on. And in fact, we now are struggling with some healthcare personnel that seem to feel that more is better. Let me put on 2 pair of gloves, 3 pair of gloves. Let me wear my gloves into every setting. And we lack then the understanding about how to use PPE effectively and correctly. So all of these challenge the health and safety of nurses, not only in one setting, but in all settings where any manner of healthcare is delivered. And while prevention is primary, we also have to recognize that illness, the ability to return to work is critical. And we've got to look to the future for collection of more data regarding immunity, and then ultimately, we hope, vaccination. So I want to stop at that time just in providing that background information and turn it over to Dawn, who is going to talk about the healthcare worker and COVID-19 exposure, and then how we look at exposure and illness before we move to Montre, who will talk about returning to work. So Dawn?
You know, as we were preparing for this session, we went back and reviewed your registration forms that each of you completed. And about half of our audience today is from out of the state of Kentucky. And the majority of you are nurses. Ruth, Montre, and I are all nurses, and we are so excited to see so many of us wanting to learn and teach and share information so that we can provide the best care for our patients and their families. As Ruth said, we're also very grateful to have Delanor here from the Kentucky Nurses Association and Andrea representing the State Department of Public Health for us. So if you'll just focus on the right-hand side of the slide for a moment, this is just a little bit of information about our state. We currently have about 4.5 million people living in Kentucky. And as of yesterday, of that 4.5 million people, only 110,000 people have been tested for COVID-19. That's only about a little over 2.5% of our population. And of those 110 tested, almost 7,000 of them have resulted positive. And we've had 321 deaths. So I think this shows you that the information that goes out to the public can be a little bit deceiving. To the left on the slide, we have about 300 long-term care facilities in the state of Kentucky. And as of yesterday, with only 84 of those reporting, we have identified 889 positive residents. There has been 179 deaths. And what we found fascinating was the amount of staff members that were positive, 365 with 2 deaths. So we had the opportunity to talk with several nurses that work in long-term care who had tested positive for COVID-19. And as the literature reports, they were asymptomatic. Many of them also decline a flu shot annually, but that's another topic. But talking with these nurses who are caring for this very vulnerable population, that kind of guided our decision on how to do our case study today. So let's go ahead and jump in on the case study. We have Jane. She's a 60-year-old registered nurse. She's employed at a long-term care facility. Wednesday morning, while she was doing her rounds, she found Bill, a 73-year-old male resident. He was sitting up in his bed and he was actively coughing. He complained of feeling cold all over, his throat was sore, and he just didn't feel well. So Jane puts a surgical mask on him and completes her assessment using standard precautions. So let's just take a moment to look at Jane's potential exposure to the SARS-CoV-2 virus or any respiratory virus. She did have contact with him without personal protective equipment. She entered into a closed environment. She was in his room without any closed equipment. He was coughing. He was contaminating his environment. He was contaminating her stethoscope, the thermometer, the blood pressure cuff, perhaps the table around him. So let's just take a second and do our first poll question. How many of you all feel that Jane experienced exposure? Okay, it looks like the majority of you feel this is an exposure. Okay, so let's continue. So after completing the assessment, Jane goes out and finds her charge nurse, and she discusses Bill's new onset of symptoms. So she was directed to place Bill in respiratory and contact isolation and obtain an NP swab for COVID-19 testing. And on Thursday, Bill received his result, and he is positive for COVID-19. So that Thursday, when he received his result, Jane was off from work. So she came back Friday morning to learn that 10 other residents that she had been caring for had been tested for COVID-19, and all of them resulted positive. So later that day, Jane is tested, and then on the next day, on Saturday, she gets a call from the charge nurse and says, "You're positive too." So traditionally, we have dealt with healthcare worker exposure by identifying the exposure, then monitoring for signs and symptoms of disease or illness, and then providing appropriate post-exposure or illness management, perhaps like prophylaxis. So an exposure, I'm exposed to flu all the time. That's what we do, we're exposed, but it doesn't mean we'll become ill. So we continue working, and then if we become ill, then we can either test, if a test is available, or clinically we can make a diagnosis. And then we follow the guidance of our work facilities, which is usually go home and till you feel better. But now let's introduce the SARS-CoV-2 virus into our exposure response. And let's look at Jane as an example. So Jane experienced an exposure. Bill was coughing. He was experiencing chills, not feeling well. And Jane did not have any symptoms. The only reason Jane knew she had this virus was because the facility decided, oh, we've got a bunch of people now testing positive, maybe we should test our employees. So she was tested and she was isolated at home. But let's say she wasn't tested. What would she do? Well, she would continue to work, and then based upon the CDC's guidance of symptoms, she would self-monitor, watch for symptoms, and then if any of the symptoms developed, with the cough and the shortness of breath, of course, being the two very concerning ones, or at least two of the following, which are fever, chills, repeated shaking, muscle pain, headache, sore throat, losing our sense of taste or smell, or any diarrhea, then now we consider her ill. She would self-isolate and then again follow the return to work guidance. Now, unfortunately, the SARS-CoV-2 virus has this unique ability to infect us without causing any symptoms or illness. So now we must all assume that we're infected with this virus and that we can transmit it to one another. And many of us, as we know, will not have any symptoms at all. So now our contemporary healthcare worker response kind of removes the exposure because we have to assume all of us are exposed. And now we have to look at prevention. Until we get a preventative vaccine available, we're really forced with following the flow of the CDC recommendation for universal masking as a source control. And of course, that source control matters depending upon where we are at. If we're in the hospital, depending on what procedures we're doing, we will either use a surgical mask or we may require using the N95 respirator. Using the universal masking protects all of us from one another. It protects our family. It protects us from the families, our visitors and coworkers. When we are out of our work environment, when we are in our schools, at events, or in our workplaces, we should wear our cloth face mask. If we're ill, we need to stay at home. We need to practice our social distancing. We need to wash our hands often. If we cough or sneeze into the elbow or onto a tissue, then we need to make sure that tissue goes into the appropriate container. And then clean the surfaces that we touch frequently with disinfectant. So this concludes my little part of presenting our case study. I would ask, are there any questions or for clarity that I need to answer? Okay, if not, let me ask, would someone, just one of you, like to share an example of how you're managing exposure of your healthcare workers?
Feel free to put this in the chat or just go ahead and unmute yourself if you'd like to comment or have a question.
Can you hear me?
Absolutely.
So I have a question about when you have employees or staff that are tested positive, no symptoms, and so our policies, they go home and self-quarantine for 14 days, and then they can come back. So my question is, aren't they still carriers? And can't they still infect other people?
Yes, and that is exactly what the CDC would recommend. If you have a positive test, that employees should go home for at least 10 days.
I think Montre will talk a lot about the return to work, but I think one of your parts of your question, I think, is extremely interesting and represents one of the challenges we have with this particular virus. This virus is an RNA virus, and RNA viruses are so odd, and that is, you can have someone that tested positively, so the PCR, the nasal swab, and hopefully NP. Let me clarify that. The best test, the gold standard test for determining illness is a nasopharyngeal swab. Now I say this because as a nurse, I want the best test. Don't give me a test where I may have 10%, 15% accuracy or that sensitivity, specificity. Give me the best chance to know my status. And so I bring up the idea of nasal swab, or even worse, oropharyngeal swab is probably 50%. So get the best test for your nurses. What we do in the community is going to be a very different animal. For nurses, the best test. So if I do a nasopharyngeal swab and then I've got results back, I can retest you at intervals to see if the virus is still present. The test actually tests for presence of that RNA. So what that means is I may not actually have live virus, but the test is still positive because it could be leftover RNA. That RNA may not be part of a live virus. So this is one of the challenges that our colleagues in dialysis may be experiencing. And what we have talked a lot with that group to say, great, I've got a patient now that has been persistently positive. Some that in our experience have been positive for maybe 30 or more days. So they have been tested repeatedly, but the test is still positive. They have no symptoms, but we're still capturing either the RNA or the virus itself. So understanding the limitations of our test are quite challenging. But as you said, well, what do we do? How do we rely on that? And I think this is why our Kentucky Department for Public Health offers us the opportunity of test-based and non-test-based strategies for returning to work. Now, I don't think they did that, and Andrea might correct me if I'm wrong. I don't think the state developed that to provide necessarily wiggle room. I think they provided that because we may not have access to enough tests to actually use that to make the decision. But if you have an individual that still tests positively, we really don't have any choice other than to say you still have a positive test. You are still restricted from work until you have 2 negative tests at least 24 hours apart. Without the test, we make the assumption that there will be resolution and no live opportunity, no virus opportunity for transmission exists. And so you'll be able to follow the non-test-based strategy. I don't know, Andrea, do you have any comments? I'm not sure if we've been able to keep you on the call, but if you have comments or clarification, feel free. I'm going to assume she was drugged back to the world of the working at KDPH.
We also have a question from the chat box, if that's okay, if we can go ahead and answer that. We have Kristen, who's the infection preventionist. She's a BSN RN from Home of the Innocents. We have a very fond down the street relationship with them. They're just down the street from us right here in Louisville. And she said, we have been very fortunate to not have any positive HCP. If anyone is potential, we ask them to leave. If they are tested, they do not return to work as we follow CDC guidelines. They have to be 3 days afebrile with no fever-reducing medicines and improvement in respiratory symptoms and 10 days from symptom onset. We are practicing universal masking. We also have been screening team members for 2 months, and they must pass that prior to coming in. And if you, Home of the Innocents, for you all outside of the state of Kentucky, they do take care of medically fragile children.
This is excellent. I think that kind of goes back. Dawn, you had one of the, and talked about universal masking and asked the polling question about individuals. Are they working in a setting where masks are required all or part of the time at work? What did those results look like?
I believe Montre, wasn't it?
And Montre will elaborate more on that.
Mm-hmm. Yeah, it looks as if we have about
maybe 60%,
not too many, maybe 60% of you that it is required to wear the mask at all time. But it sounds like you're doing a great job at Home of the Innocents.
Excellent. Very good.
Do you have any other questions, clarifying questions for the case presentation or any comments?
Would someone be willing to share what your biggest needs are to prevent exposure among your healthcare workers? Okay, well, thank you for letting me be a part of this. I will turn the discussion over now to Montre. She's going to help us understand how to get our healthcare workers back to work.
Thank you, Dawn. Hello, everyone. My name is Montre, and I will be covering this portion of the session on the healthcare worker returning to work content. Here are the items that we're going to cover. we will go over a case study as an introduction to the Kentucky Department for Public Health Guidance, Return to Work. Next, we will go over the Return to Work document. We will be going over the document section by section so that everyone can understand the content. And finally, we will briefly cover the CDC guidelines so that everyone is aware of the information. Let's get started with the case of Sue. She is a 25-year-old registered nurse working in a float pool at the local hospital. She's reported symptoms consistent with COVID-19 and was subsequently tested and was positive. She has been off work for about a week and is beginning to feel better. She is calling to see when she can return to work. The question, polling question would be, what does Sue need to consider before returning to work? And what information does Sue need to communicate to her workplace?
Feel free to unmute yourself again by holding down the space bar and then letting it go. *6 if you're calling in audio only, or you can place that in the chat as well.
So I think part of this question is, when Sue is thinking about coming to work, to me, and what we have spoken with a number of nurses going back to work, they're primarily thinking about two things: my patient and my family. So how do I safely go back to work so I don't then experience exposure to my patients, or could I potentially infect my patients? And then secondly, what about returning to work? What if will I have the necessary protective equipment that I need if I use universal masking? What does this mean to me regarding the need to continue PPE? So most commonly, the questions are about self and patient.
We have some comments in the chat from Krista. Sue must have improving symptoms, afebrile for 72 hours without fever-reducing meds, and bowling, afebrile without meds for 3 days. C. Jordan, 72 hours afebrile without the use of antipyretic medications. Heather, 2 negative tests 24 hours apart. And C. Jordan, or if test-based, 2 negative tests 24 hours apart. We have agreements with other comments, and we also have, she needs to consider who she will be exposing while still positive, must not be sick to return to work. So thank you very much for your comments, as well as Monica will touch back on your comment in a little bit.
Okay, now we're going to go over the Kentucky Department for Public Health Guidance, Return to Work. This document is included in your resources. It was a packet that was emailed to you, and it came with the agenda. If you cannot find the documents, please let us know at the end of the session, and the information will be resent. This public health guidance document uses a non-test-based strategy to determine resolution of COVID-19, clinical disease, and likely infectiveness, the organism's ability to infect you. This document applies to healthcare personnel returning to work, all persons returning to work and or seeking clearance from isolation, and residents returning to confined population environments. Examples are long-term care facilities, behavioral health, hospitals, and prisons. Here is where we're going to go over a patient who is symptomatic. A visual will be coming up on the next slide so you can better understand this content. This content refers to healthcare professionals, employees, people in isolation who are symptomatic and laboratory confirmed, or symptomatic and clinically suspected with COVID-19. You need to be excluded from work and or remain in isolation until all of the following are met. At least 3 days, 72 hours have passed since recovery, defined as resolution of fever without the use of fever-reducing medications. Medications such as Tylenol, Motrin, and improvement in respiratory and other symptoms. For example, a cough, shortness of air, diarrhea, and at least 10 days have passed since symptoms first appeared. Additionally, upon returning to work, a surgical mask is worn for universal source containment. That means that the stuff that you don't want to give to others and other people's stuff that don't want you to have in the workplace. Here's how you calculate how to return to work. Let's start at the bottom of the slide. You have 7 days of symptoms. It could be a cough, body aches, shortness of air, etc. After this episode, you must have 3 days without symptoms. That means no cough, no fever, no shortness of air, etc. Remember, you must not be taking any fever-reducing meds. After the 3rd day, you can return to work. Going to the top of the slide, you have 7 days of symptoms plus 3 days without symptoms equals a total of 10 days. Here is another example to calculate return to work. Again, let's start at the bottom of the slide. This time you have 12 days of symptoms, then you have 3 days without symptom. The same criteria applies with no fever-reducing meds. Going to the top of the slide, you have 12 days of symptoms plus 3 days without symptoms equals a total of 15 days. It doesn't matter how many days you have symptoms, the key is the 3 days without symptoms. In the previous slide, we talked about when a person is symptomatic. Now we will discuss when a person is asymptomatic. It is the healthcare professionals and employees with laboratory-confirmed COVID-19 who have not had any symptoms. Excluded from work until 10 days have passed since the day of the first positive COVID-19 diagnostic test, assuming no subsequently developed symptoms since that positive test. Additionally, upon returning to work, wear your surgical face mask for universal source containment in the workplace. There should be 10 days after a positive test and no symptoms. After this, you will return to work with a mask. Now we will go over the return to work practices and work restrictions. Source control. Remember, source control is you got stuff that you don't want people to get from you, and you don't want stuff that people have to get towards you. In the healthcare setting, you need to wear a surgical mask instead of a face covering. You need to wear it at all times until all symptoms are resolved, or until 14 days after illness onset, whichever is longer. Make sure you follow the guidelines at your facility. It was the information covered on the previous slide. You may have a mild cough, you must wear a mask. Some people may have a cough that may last up to 2 weeks. In a non-healthcare setting, you need to wear a face mask or cough face covering. An example will be going into public, going to the grocery store. You still need to wear a face covering. You need to wear a face covering at all times until all symptoms are resolved or until 14 days after illness onset, whichever is longer. After this, continue with source control in the healthcare setting and follow the Kentucky Department for Public Health and the CDC guidelines when in public. Make sure you also monitor yourself for symptoms and signs and symptoms.
If you haven't already answered the poll that's on your screen of how many of you are working in a setting where masks are required all of the time at work, please do so now.
And hey, Montre, it strikes me that with COVID-19, we're learning so much about the physical presentation of illness and the occurrence of pneumonia in the patient population. So all of us have worked with patients with pneumonia in the past, and we know that your pneumonia may have the organism causing your pneumonia may have resolved, but the changes in your pulmonary architecture are still present after pneumonia. And you may cough for weeks, or sometimes people will cough for months after pneumonia. So the challenge in this is very similar to the patients that we have, our coworkers. We're talking a lot, they'll say, oh my gosh, I've got allergies. what am I going to do when I'm either concerned about being infected with COVID-19 and have allergy symptoms, or maybe I was already exposed and I'm returning to work and now I have allergy symptoms. So my point is that we also need to kind of know what our baseline, what our normal baseline is, and be able to factor that in. So as we are working with healthcare personnel who are trying to figure out when can I return to work, you may have healthcare workers that are saying, you know, I feel better, my fever's gone, other symptoms are gone, I still have this residual cough that continues, that there's nothing magical about this 14-day period, right? That if you continue to cough and you can project whatever you have into the healthcare environment, then continue to wear that respiratory protection. You're right. So again, and you've got like a respirator in one hand and a surgical mask in the other, and that reminds us, whatever you're doing, if you're dealing with an aerosol generating procedure, you're going to wear a respirator. Even though you may be wearing a surgical mask all the time, you have to switch that out.
Well, can we just show that on your webcam, on your laptop, so they can get a nice little close-up of the mask, showing it on your camera?
Sure. So now you've got the respirator in left hand and surgical mask in the right hand. Good.
Yeah, she's a wonderful model.
And that's important, yeah, making sure that we all kind of understand terminology. The N95 is a respirator. It's not a mask. But we have surgical masks or procedure masks that enable us to have that not only barrier protection, but many of the surgical masks, just by nature, are fluid resistant, have some measures. So they're able to tolerate the wet cough, both coming at us as well as our wet cough, or that we all know about our insensible loss, or the respirate, the fluid that leaves us just during normal breathing. That type of mask is able to contain that for some period of time. But I think our challenge in returning to work and the resolution of symptoms is that we will have healthcare workers who will probably say, I don't think I can come back to work yet because my symptoms aren't completely gone. And so you may have to deal with that and determine then organizationally what your approach is, or even what is better is to have these individual conversations with nurses who are concerned about returning to work, so they have an understanding about what are we looking for with respect to these symptoms that represent a problem, and then what may be more representative of either your baseline health or the baseline we can expect as you are recovering from a more significant COVID-19 disease, which might include the pneumonia symptoms.
I do have a comment from Monica here in the chat that has to be returned to. She said, at Berea College, we have not had any positive COVID-19 cases. We are developing guidelines for protocol for opening campus in the fall. Universal masking for the students with symptoms. We ask that they call the White House Clinic, our designated student healthcare service, and get screened by a healthcare provider. The healthcare provider orders testing. While waiting results, students are in conjunction with nurses in the nursing department.
Great. So we know one of the biggest issues in doing all this has been our varying availability and the access of testing. And Dawn will often remind me, you know, remember, Ruth, we have only been working with COVID-19 for how long? 5 months now, right? Yeah, I mean, it seems like a lifetime ago that we first started dealing with this, but the number of changes that we have made and the strides that we have made in addressing this are, to me, absolutely incredible. It seems like forever, but we worked at lightning speed. But when we first began to struggle with this, remember, there was no test in the United States. Nobody ever had to perform this. Not only that, we didn't have enough swabs because, you know, if we've got however many, 328 million people in the United States, that means we've got 328 million people that are wanting to be swabbed at least once. And we just don't have that amount of capacity yet. But our boss reminds us frequently, remember, everybody in the whole wide world is working on COVID-19. So industry is working on how do we have more test availability and more supplies. So we know we will get to that point. Our challenge is what do we do in the interim, and then make sure, again, from my perspective, there should never be a nurse that is on a ventilator with COVID-19. That should not be happening. We should have enough attention in our healthcare facilities so that we are testing patients, we are testing nurses, so that doesn't have to happen. And that means as nurses, we have to require the best. If we don't have enough personal protective equipment, we need to be working with our health department, local health department, to help us access that, and to back to the state with our emergency preparedness and planning. If we don't have access to testing, we need to be having those discussions to say, wait a minute, if you can test in the parking lot of the grocery store, then you can test your nurses in the hospital and your patients in the hospital. And that's something that we need to make very clear, that we can't do without our nurses. So let's not start now doing it.
So there's another comment that said, we know U of L is opening in the fall. Can you talk about some of the precautions on an academic setting in an academic environment?
Yeah, I think that we probably have a couple of folks on the call that may have some insight as well, but I know that there is aggressive planning to helping all students return to campus. And so that means we're going to have to educate a lot of very young individuals. And I say that because I remember when my own children were 18 years of age, trying to convince them that they are not bulletproof and not COVID-19 proof is going to be quite a challenge. So we're going to have some ability to test. At the same time, when I think about our nursing students, they need clinical expertise. And so I think the reality is, and something that we need to get very firmly in our mind, is that there is no wave that is going to wash this disease away. It is here to stay with us. Our challenge is going to be, how do we live in the community? How do we open up the community, knowing that disease is going to happen, and that we have the ability to watch what is happening in healthcare, so we know if we lose the surge capacity in healthcare, that's the message back to businesses, academia, and everybody to say, turn off the faucet. Let's have people then back in self quarantine until those numbers or that surge capacity comes back down. But we'll have to have the ability for students to recognize illness and to be able to self-isolate, and that we will have to have some ability to provide testing, again, to those that are involved in healthcare specifically. If somebody is ill and you can go home and self-isolate, testing does not need to be a priority for you. However, those that are going to be working with ill patients, it is a priority, or those that are working with patients at risk, it is a priority. So we may have some that have been involved in developing some of these policies from the academic side.
We had from Krista and Beverly, they said they're on the task force here at U of L with the School of Nursing, and there's lots of hard work going on making those plans you were talking about. And Beverly made a great comment that it's going to take the entire university working on this plan together as a whole to make it work and make it happen. Thank you both for those comments.
Yeah, good. For the employees that are in a healthcare facility, they should know that surgical face mask for source containment does not replace the need to wear the N95 or higher level respiratory equipment or other PPE for protection for aerosolized pathogens, including when caring for patients with suspected or confirmed COVID-19. Know that N95 respirators with insulation and the exhaust valve may not provide source control. May prevent source control. Be restricted from contact from severely immune-compromised patients, for example, transplants, until at least 14 days after illness. Continue to work if exposed, but not symptomatic, but wear a surgical mask until 14 days, at least 14 days after illness.
Can I make a comment? I've seen a lot of healthcare workers wearing the N95 respirators that have that exhalation valve, that little exhaust, it's like that little square right in the middle of that respirator. If you have those in your facility, please make sure that you know the purpose for that exhalation valve. They are designed not to be source control. That means they're not for the wearer. okay? That exhaust valve opens up or can open up when they exhale. So if you are ill and you are wearing a respirator with that exhaust valve, that provides an excellent funnel for whatever respiratory particles are in your upper respiratory tract to just be projected right out into the environment. So this is a time to kind of pause and make sure that you know what type of PPE is in your facility, that you are aware of that. And those of you that are teaching nurses or teaching students, make sure that they are aware of the different types of PPE and their limitations, so they can always select the best type of respiratory protection for that particular purpose. So stop and get to know, become one with your PPE. So get to know your PPE so you can then answer those student questions and direct them, and even questions of experienced nurses. They may not have had to think about that before. So move on to the next step.
Okay, here is the CDC guidance for return to work. CDC uses either a symptom-based strategy, a test-based strategy, or a time-based strategy to determine return to work. To exclude from work and or remain in isolation until all of the following are met. Resolution of fever without use of fever-reducing meds, and improvement in respiratory and other symptoms, cough, shortness of air, and negative results from a FDA emergency use authorized molecular assay for detection of SARS-CoV-2 RNA from at least 2 consecutive respiratory specimens collected greater than 24 hours apart, a total of 2 negative specimens. Also, make sure you use a face mask for source control and self-monitoring. Now I will turn the session back over to Ruth, who will review the healthcare worker immunity and COVID-19.
We've got a question in the chat from Beth. Where is the best place to get information about the different types of PPE and their limitations? Looking for consistency, and there are so many sites out there, but they all do not concur.
Yeah, this is a great issue, and I think kind of a problem. One thing that I always recommend is that, kind of a first place to go, and many of us, I didn't know this even when I first started in infection control. One of the first things that I learned, because I did exactly what you're saying. What's the seminal source? Where do I go from the very beginning? And so I learned that personal protective equipment, these standards for development or the attributes of PPE are actually outlined in specific documents. These standards are outlined by the Association for the Advancement of Medical Instrumentation, also known as AAMI, A-A-M-I. AAMI has specific standards and will say these are the attributes of a procedure mask. These are the attributes of a surgical mask, because they're different. And this is why you'll see some masks that have ear loops and some that have ties. Those are 2 different types of masks. Those are not the same, and they will provide different levels of protection. So go to AAMI, the AAMI standards. Now, you may have said, great, I'd love to, but I got to pay for them. Actually, you do. Most healthcare facilities will have a subscription, or will be actually a member of AAMI, and then you can quickly access that through their library. If you can't, then you can go onto the internet and then search AAMI standards for masks, AAMI standards for gowns, AAMI standards for gloves. And many of the companies that produce those items will have very nice sets of presentations or one-page tools or resources for you. This has become very important, because right now, while we're wearing gowns for protection against COVID-19, we need to know what type of gown is the best type of gown. And we'll know, if you're like me, you've had isolation gowns, those yellow ones that if you look at them very long, they'll rip. Or the plastic ones that you think if You know, here I'm over the age of 50, and you put me in a plastic bag, and I've become personally responsible for global warming. I'll like heat up the joint. So different types of gowns are appropriate for different types of uses. So we need to know, what are those AMI levels? So if you look at a gown, you'll see AMI level 1, AMI level 2, level 3, level 4. Level 4 is the highest level of gown. Those are the ones that you'll typically wear in the operating room when you've got a really bloody procedure. They're almost fluid impervious. So get to know your types of PPE, get out on the internet, or you can ask your whoever your vendor is for different types of PPE. Many of them, like Medline, has a very nice institute where that you can go through and look at training material. But go to the big industry providers, ask for information that outlines the AMI standards, and that will give you the most accurate information about a particular product. If you don't know what to ask for, you then get all kinds of varying pieces of information, but that I think is one of the best places to start. I also want to make a comment Montre talked about, and I think on your last slide you talked about the PCR, that it's emergency use authorized, and it has to be a molecular assay. That is the long way of saying that a PCR nasal swab, the NP swab that we use, that is a molecular test, that is the gold standard for us to determine presence of illness. And that's why CDC is saying that not just any old Q-tip up the nose will do. It has to be a specific type of swab that is managed in a very specific way, and the test is run using an authorized testing platform. This is, I think many of us saw the news where we saw these tents popping up all over town with people that'll roll up in a van like a clown car, and everybody gets out and they're going to test you and, you know, charge your insurance or charge you cash. That we've had, unfortunately, opportunities for people that are unscrupulous, that are providing services that are not accurate, and they have taken advantage of populations. So there are several things to check for when you are looking at a test. Number one, does it meet, is it FDA approved, or in this case, as we are producing tests, it has to be authorized by the FDA. That is the first thing. The second is the test being run in a CLIA certified lab? All of us know that if you have certification or their accreditation, you have to meet certain standards. And I have to say, I've never met a group that is more anal retentive than people that are working in a CLIA certified lab, because they are attentive to detail, they require quality, and they know that if they are giving you a result, it has to be accurate. And so they are going to be extremely attentive to process. We are learning with these tests for COVID-19 that many mistakes can occur in technique, both in collecting the specimen as well as running the test. So I think those are the two most important things to ask for: is your test an FDA approved test, and are you running your results in a CLIA certified lab? And people will say, well, neither one of those are important. Well, let me tell you categorically, they are important. And I'm saying this from the perspective of a nurse and experience. As a nurse, I want the best test for a nurse at the bedside, because he or she is going to make decisions based upon the results of that test. So we've got to make sure they're accurate. So I know I was raised a Southern Baptist, and this is sort of like a pulpit, and I feel the Spirit move me, and so all of a sudden I'm like in a sermon. So I'm going to try to get back on track so that we can.
And you posted the resource for the nasal swab?
Absolutely. Dawn reminded me too, one of the resources I think is the video that we got from the New England Journal of Medicine. They had a great, a couple of resources. I think the one that we posted might be a little bit longer video, and it is it's about 5 minutes, but it shows the actual procedure and gives you, as a nurse, we want to know the theory behind that, the why. But it gives you very specific information about performing a nasal swab. So, again, remember, you've got to use a certain type of swab that actually grabs the virus in the nasopharyngeal area. So it has to be a flocked swab, or one that's kind of rough. It also has to be made of particular types of material. So no cotton, no wood. Both of those interfere with the test. and it can't cause bleeding, because if you have a bloody specimen, it interferes with the PCR, the running of the ability to capture and recognize that virus. So we have to be very careful about the type of specimen that we submit for testing, else it won't give us the right results.
And that's available to you in box for you to watch.
Okay, let me start with our case study. So we have an individual, RC, has recovered from his COVID-19 symptoms, but he was not tested. He followed the guidance, he self-isolated for 14 days, but now he's curious, did I really have COVID-19? And I want to know, if I had the infection, am I immune? So he just heard about a drive-through testing event that was going to be at his church this weekend, and so he's thinking, this is something maybe that I want to do. Next slide. Well, but he's been talking to his coworkers about the test, and he's thinking, okay, what will this test tell me? Is it going to tell me if I have antibodies? Does this mean then, if I've got antibodies, does this mean that I maybe not have to wear a respirator when I go back to work? You know, I'm concerned about that, because he's saying, you know, the respirators are bothering my facial skin, and I know we don't have enough supplies. So if I'm immune, and if I have a test that shows me that I've had disease, then can I just say, forget all of the PPE, I'm protected, I'm safe? Well, we know that, that this unfortunately is not the case. That we know that we have had a lot of tests that have been developed that use just a finger stick test. And we've looked at them, it almost looks like a little pregnancy test. You drop some blood on one end, and then the reaction occurs, and then you'll get then the bars to tell you if you have evidence of infection. The problem with these are, first of all, very few of them are FDA approved. So they have made it to the market, but they have not gone through an approval process. And they really are an example that a bad test is worse than no test, because we are seeing then an incredible rate of false positives and false negatives. Again, those of you that have expertise in epidemiology will also be able to affirm that if you are testing in a situation where the incidence of disease is relatively low, then that can impact your ability to give you accurate test results. I mean, we may be testing everybody who is potentially negative. Well, then we may have some false positives, because at some point you're going to have some misalignment with the test. No test is 100%. And so because of that, we have statements from the FDA, the Food and Drug Administration, from IDSA, or the Infectious Diseases Society of America, and the World Health Organization. All have issued statements that have said that there is concern regarding the unreliability of many of the currently available rapid finger stick antibody tests. So I get one drop of blood, and I'm trying to make a decision to see, do you have antibodies in that one drop of blood? But also, remember, we have the endemic coronaviruses that circulate all the time. These are the kind of the common cold virus. And the tests have been found to inaccurately identify one of those endemic coronaviruses as COVID-19. So you may get a test that is positive, but you may not actually be positive. So we don't want nurses to be using that to make some of the decisions that our case study talked about. Here, our next slide, that we know testing for immunity is also done via a blood draw. So if I have a tube of blood, I can spin that and I can look at that in the lab, and that's going to concentrate any antibodies that are present. And we feel like that type of test may be able to provide us, at least take another step toward a valid test result. So if I have the choice between a finger stick and blood draw, I know many people would rather have a finger stick, but if I'm looking at accuracy of that test, I'm going to be more inclined to err on the side of the test that is done when I can spin that blood down and then concentrate those antibodies. We've got a lot of work. Again, I said the whole world is working on tests and developing better tests and improved responses so that we can get specific information that is relevant for us. We need to know what type of antibody. Is it protective, and how long it will last? This is what I need to know to let me know if I have protection. So our questions about immunity: are the antibodies that were identified in that test, are they specific to this coronavirus of interest, or are they cross-reacting with the endemic coronaviruses? Are those antibodies protective? If they are protective, do I have enough of them, and how long will they last? Those are critical questions for immunity. So remember, a positive test does not indicate protection against COVID-19, or doesn't protect against future COVID-19 infections, and doesn't definitively indicate that we had a prior exposure. A negative test does not exclude either current or prior COVID-19 infection. So you may be saying, well, then why the heck am I getting tested? That may be one of the questions. That many of the testings that are done now are actually part of research that are going to say, we don't really know what is happening. We're going to try to gather information that may teach us about what is happening, but in all reality, you may not be able to use those results to guide your decision-making or your practice decisions. Testing for immunity typically is done during an infection, and antibodies are produced. These antibodies, also known as immunoglobulins, can indicate several things. An IgM can indicate current infection. IgG gives us information about prior infection. So when we're looking to see, have I had rubeola or measles in the past? Am I immune? I'm going to look for IgG. So the infection may also result in antibodies that can give us long-lasting immunity. So we know if I have had rubeola or measles in the past, if I have antibodies, those antibodies are extremely durable and have probably been immune for life. However, some diseases produce antibodies that are not protective, and HIV is an example. When we do an HIV test, we are testing for the presence of the antibody, but clearly that antibody is not protective. We also know that viruses change frequently, so a prior antibody may be ineffective with a current disease, such as influenza. This is why we have to get vaccinated every year. So immunology, or understanding the science of immunology, is very complicated, but we know that there are a number of questions regarding our immunity that are important for us. We don't know, after COVID-19 infection, if the antibodies produced during that infection are protective. So I may have antibodies. Yes, my antibody test may be positive, but I don't know if that protects me. If those antibodies are protective, we don't know how much. So we can relate to this because after we had our hepatitis B vaccine series, all of us had a hepatitis B antibody level done. It had to be greater than 10 international units, or that wasn't, once you have 10 international units, that tells us we've got enough antibodies to be protected. If it's less than 10, we don't have enough. We've got some antibodies, but not enough to be protective. So we know that we are, in essence, antibody negative. Protective negative at that point. We also don't know how long they last, that different exposures to diseases provide protection for varying lengths of time. So until we have that information, we cannot make definitive decisions about antibody testing. So the last thing we want a nurse to do is to say, I have disease, I've got antibodies, so if somebody needs to go in that room without appropriate PPE, let it be me, because I'm protected. That is absolutely an inappropriate response. So we may need to make sure any nurse that has any type of antibody testing, we need to make sure they understand the limitations of that test so they do not make decisions that may cause them illness, may cause them harm, or may put them in a situation to harm others. Next slide. All right, so enough about antibody. I know everybody's thinking, oh, crud. You know, this isn't exactly what I thought about antibody testing, but I hope it prompts you to read more, get on the internet. There's some excellent pieces of information. Medscape has some great just reviews about COVID-19 and immunity that I think would be very helpful. All right, there's currently a lot of questions about treatment. We've all read about hydroxychloroquine and whether or not it works. I think everybody has said, don't add azithromycin because of that prolonged QT interval and the problems associated with azithromycin. But I think that we're seeing a lot of information now that may not be the answer that we had hoped it would be. Remdesivir is an antiviral that I think Gilead, produced by Gilead. A lot of good information about remdesivir. Unfortunately, I think at last count they had like 120,000 doses. And since it's a 5-day course of treatment, that's not going to treat a lot of patients. And I think they did a very interesting thing as a pharmaceutical company. They said, wait a minute, we cannot possibly decide who gets these very few doses. So we're going to give it to the federal government. The federal government then is going to decide where should it go. And ideally, it would go to places where you've got a tremendous amount of disease. Again, that's not because you like that city better or don't like that city. The idea is if you have so much disease that you're stressing your surge capacity, then you've got to get that amount of disease back down to keep that community from collapsing. So I think it was a very wise decision to put that in the bailiwick of the federal government. We'll see what happens with remdesivir and other antivirals, but again, there are so many clinical trials going on, hundreds of clinical trials going on now to look and see what some of these medication answers are. Again, that shows you what happens when the whole world is looking at a single disease. One approach I think that many of us are aware of that has shown signs of some effectiveness has been getting blood from an individual who has been sick with COVID-19, getting their blood, getting the plasma from that whole blood, and then administering that plasma or transfusing that plasma into a person who is ill with the disease. That gives them the immunoglobulins from the individual who was sick to try to see if that produces any effect. Currently, there are several national studies that are going on. Probably the biggest one is between the American Red Cross and the Mayo Clinic. I guess some of the problems with that are you can't have any directed donation. I couldn't say, Dawn, I'm O positive, you're O positive, let me give you my blood. I can't do a directed donation, which I think impacts the embracing of this as a measure in the community. But I think we'll continue to look at this. One of the downsides that we're seeing from this transfusion is that when I give you, if I give Dawn some of my blood, I'm also giving her my clotting factors. And so she may actually begin to get some of the positive benefits of the immunoglobulins, but she may get a negative benefit from my clotting factors and then result in stroke. So, I don't know whether that's a good trade-off, I don't know. So in our department, we went around and said, okay, we need to know kind of what everybody wants. So tell me what you want, because if you get sick with COVID-19 and I'm going to come, give some opinion about your treatment, tell me what you want to do. And everybody in our department wants something a little bit different. But I said, for me, I just want a nurse who knows how to take care of me. I want a respiratory therapist that can manage a ventilator. I like a ventilator. Give me those things and then let me see how I'm going to do, because I don't want you to give me a treatment where we still haven't found the downsides, whether it's medication or blood product, that support me, and hopefully I'll be able to make it through that. So you all are all my witnesses. I guess that makes each of you my own personal healthcare surrogate. But I'm in hopes, but I know the best thing for me is going to be, I want an experienced nurse, and I need the medical equipment, and I want to be cared for by a knowledgeable set of healthcare workers.
We have 130 people joining us.
So I've got a lot of
on your side right now.
So, but I think this is important for us to think about. What do we want done for us, and what do we want done for our families? And as with any other stressful situation, don't ask me to make a critical decision during a very stressful time. Let me think about it so I can get it under my head a little bit. All right, so vaccines. We know at present there are about 30 candidate vaccines that are under study, and there are a couple of indicators. If the virus is stable, that means if it doesn't undergo some very key mutations, then that means one vaccine may last a long time. We still don't know enough about this. We still are reading about, about the virus. And we're learning, even in Louisville, we learned that individuals that were sick, when we looked at the genetics of some of the viruses from individuals who were sick, we saw some that said, hey, your virus came from California, and others, oh, your virus seems to be more locally grown. So we're not seeing consistency. So that lets us know that there are some changes that are occurring in the virus, but we don't know how significant those changes are. We think that even under the best of circumstances, regardless of what you read, that we're still probably a year away from a vaccine that is available to the general population. So that means here we are in May right now, we are going to be entering influenza season before too much longer. And one of the big issues that we as nurses are going to need to address is how do we then interest individuals in getting a flu shot this fall. Already, Dawn and I were talking about some of the literature that is saying parents, we're already seeing parents of children that are not taking them in for routine immunization visits. So are people going to be afraid to come out of the house or to come out and go into the pharmacy or go other places to get influenza vaccines? So we're really going to have to stress not only with our colleagues, but with our families and our patients that the last thing we want to see is somebody who gets sick with flu and then your baseline health drops a bit and then become infected with COVID-19. So what little bit of reserve you may have had to help you live through COVID-19 may be gone just because you had influenza previously. So, we're going to have to enter this flu season in our best possible health with everything that can be done to protect us in place, and that means vaccination. So our summary then, time as we end with we'll be able to have a few minutes for questions, right?
Absolutely.
Exposure to COVID-19 and infection among other nurses has occurred and will continue to occur. We have to have a plan in place to identify known or suspected exposed or exposure situations and respond so both the nurse and the resident or patient are protected. We need to have a return to work strategy that makes sense. It's based on current evidence and has to be managed in an organized and thoughtful way. And above all, reliance upon immunity testing is not realistic, at least at this time. So please do not let or encourage nurses to make decisions regarding future infection, PPE use, or other decisions regarding their resistance or their ability or inability to become sick. Make a decision. So we've got to protect them. Our nurses protect each other. Remember, we made a promise to our patients, and that is that we will provide them with best practice care, not only one day, but every day. And in order for us to do that, to continue that covenant with our patients, we have to be healthy. So remember, this is the year of the nurse. Deliner always reminds us of that at KNA. This is the year of the nurse. That means the year of the nurse needs to be focused on the nurse. So focusing on our health and our safety is paramount if we're going to help our communities get through that. So with that, let's take any questions. And please remember, if we have comments or things that come into the chat, we will still continue to address that and then make responses available so we can continue to come together.
We've got some coming on. We have a couple of comments. One is, I think, from Terry, I think more will take the flu shots this year with hopes it will protect them. Jody Rogers, I love this comment. You are all heroes. Join KNA, stay KNA. I know Deliner is probably like a little pom-pom.
Amen.
We have, will you?
Amen.
Amen. There you go. Just so you all know, Deliner has graciously given me a KNA supporting sign that is in my yard in southern Indiana. So I feel attached now to KNA completely. We have another comment of will the U of L School of Nursing Task Force be willing to share policies or provide advisement for other schools of nursing, considering allowing nursing students to return to their clinical settings?
Wonderful.
I think if we can, we will definitely pass that on. I know we have a couple of the experts in that task force on Zoom, so if they want to respond in the chat, they can. If Ruth has any guidance on that, I know she'll provide that.
I think Deliner had a comment that I bet she's going to say, KNA can certainly be the broker for sharing information around.
Am I beginning to sound like a broken record, Ruth?
Never, never, never.
We also have a comment from, a question from Beth Hickey. What about developing a program for public health nurses or home health nurses who go into the homes to give flu shots? Could a program be designed to meet this need in the community? And Beth, I think you might have been a fly on the wall because the people in this room were actually talking about home health nurses just this past week. So Ruth, do you have any?
I think your question is how are we gonna provide vaccination in non-traditional ways? So you know, we've been working on, some of you that have been around for a while may remember in the 90s in Louisville we were the first drive-through flu shot clinic in the world, and so now there is an intense interest about trying to find new ways to provide, or non-traditional ways to provide vaccination. So that, you know, your questions about how do we do that in the home. This is an opportunity for what I think nurses do best, and that is innovate. Innovate. And you may say, well, I've never been an innovator. And I want to say, I bet you developed something that you taped together, that you used and took to work, and every day you taped a new one together. So I know nurses innovate. So I think this will be great. And you may have Beth a comment about this.
So we may want to challenge each other to the drive-through flu shot clinic record currently held by Northeastern Nevada Regional Hospital. In 2019, they had delivered 1,252 flu shots. So you were all challenged to try to break that record here in 2021.
Well, you know, we actually broke that record in 2009 when we gave 19,000 vaccines, almost 20,000 in 18 hours. We couldn't qualify for the Guinness Book of World Records because they wanted the patient list, and we said there's just this little thing called HIPAA that we can't, so we couldn't give them a list of patients so they could verify. So we missed out on that opportunity, but nevertheless, again. I don't know how to say it any other way, and Delner says all the time, nurses rock.
We all do.
Do.
So any more questions, comments, you all, again, feel free to unmute yourselves if you'd like. Holding the space bar down is the quickest way, and *6 for anybody joining on audio.
Well, I'll comment. I find the conversation about the parents not wanting to bring their children out for routine vaccinations very concerning. And I would challenge all of us to think about some ideas that we can share with one another on how to get into the homes and get these children vaccinated. And also someone made a comment about, I think people will take more flu vaccines this year. Well, we hope so, but I can tell you after talking with several nurses in long-term care who were tested positive for COVID that had not received the flu vaccine, we asked them that question, are you going to take a flu vaccine? And they're still not going to take a flu vaccine. So I think we have a lot of work to do. I personally feel that if Delano or someone who is in hierarchy really consider maybe this fall working on some kind of a proclamation to where if it's just short term, this season and possibly next season, that all healthcare workers are required to have a flu vaccine. I know that's against a lot of people's concerns, but you know, again, we've got this whole new beast here. We've got this SARS-CoV-2 virus, and I think a lot of people we're going to see a lot of people die this year that if we can't get a flu vaccine. Something to think about.
May I just say, when I worked for hospice, it was a requirement that every employee get a flu vaccine because we couldn't lose one nurse. We didn't have the luxury of not having every nurse on deck to care for the dying. So I am very familiar with the requirement that every nurse needs to protect herself so that she can care for patients.
I don't think, I have never met in my 45 years in practice, I don't think I've ever met a nurse that wanted to hurt their patient. I think it's just a matter of understanding and knowing the evidence that you can be sick and asymptomatic with influenza, just like COVID-19, and able to transmit to others. So how do we then make it available so people feel not only comfortable and safe getting a flu shot, but we feel that ethical obligation to care for our patients. So, as leaders in our field, it's important that we take this step and that we are working alongside our colleagues in every area to make this happen. As we end up today, I want to also, please, if you would, send us then information about sessions that you would like. I think we will probably be changing our approach May 20th. I think I want to take a vacation instead of moving toward specimen collection type. I want to get some feedback from the group that we have had on this call today to say, tell us what your interests are. Tell us what you want to hear about. We'll always have a placeholder just in case, but I don't think that this group is short on ideas. So let us know what your interest is in this education. Delaware has agreed to archive these sessions, so nurses will be able to get continuing education. We'll get 1.8 for today. We'll also be able to get 1.8 CE for any nurse that returns back and watches this. So tell your friends and family. Go back to the KNA website and look for information about how to view this so they also can get CE, but we want your feedback. In addition, we will be sending out evaluations to you. We will also be sending out a question. I think this is right, Kim. We'll be sending out the question to find out if you are interested in participating in a research project. We are initiating then research so that we can follow nurses over the course of another year or perhaps beyond. We're interested in seeing how nurses are faring with during this pandemic. Mental health issues. We want to look at if you have had COVID-19, what about your long-term health impact? Are you more likely to have problems with asthma? Are you more likely to have problems with cardiovascular disease? So we want to watch and see what is happening. It's almost like the Framingham study that looked at cardiovascular conditions. We're looking to see what is happening to nurses who are dealing with these patients over time. So we'll be asking about your interest or your willingness for us to contact you to involve you then in a longer term study so we can hear. Tell me what you are experiencing, tell me what you think. And again, the nurses that are living this are going to be telling us what we need to look for.
We had about 50% of those that answered that at registration that were interested. It was almost a 50-50 split.
Right. So be on the lookout. We probably will not have a session on May 20, but we will be wanting your ideas and probably have one. I'm hoping to shoot for the following week, so more information then will be coming out. We want Project ECHO to be an opportunity for this shared learning, this interactive learning, so that we get better together. So thank you so much for your participation. Kim, any comments?
I think Delaware has one before.
Ruth, I would just like to mention to everyone that's on the call is that the Kentucky Nurses Association has implemented a mental health program. I want you to know that we realize that nurses on the front line are being stressed and being blessed that they get to care for patients. But I want to remind everyone that the mental health program called Nurses Helping Nurses is available to every nurse, no matter what setting they work in. And you can get that information on our website, or you can.
Thank you, great. I think those are on Friday, I believe, right?
Yeah,
so,
we have webinars on Fridays from 12:30 to 1:30 every Friday. And if you have questions about the program, or you know someone who's being stressed, who needs someone to talk to, we have 100 nurse practitioners and nurses who are mental health experts who are available for peer-to-peer support for you and your colleagues. So I don't want any nurse to feel like they don't have some place to turn if they have a need for support.
Thank you, Della. This is just another demonstration of the value of our professional association. KNA is our professional association. There's just a group of reasons why to come together as a profession. And Delaware, thank you for yet another example, as well as your leadership. Thank you. Thank you so much.
I wanted to let you all know that Jess Petrie, who's our collections, who's our librarian here at the School of Medicine at University of Louisville, has said in the chat, in case you can't see it, our collections librarian and I have been curating a little resource COVID-19 resources guide, and the free resources tab has links to many of those that are normally paid subscription-only clinical resources. They are being made open access, so you don't need to be affiliated with U of L or any other academic institution to access any of them. And she posted a link, and I'll put that in the resource guide as well. Thank you, Jess, for sharing that. Just want to remind you all, in under an hour, you should receive your survey for feedback. This is so important to all of us, so we can cater this to you, as well as that includes your post-clinic evaluation survey for your CEs. So if you did not officially register for this and you are still on the call, please send me an email or put it in the chat so we can get that access to you. You saw how important these case-based learning is, so please submit cases, scenarios, or even success stories to us regarding infection control and COVID-19. You'll receive that email to do so as well, and you can select which date is your preference to submit those cases. So thank you so much on behalf of all of us in this room, and I know all of us on this call. Thank you so much, and happy Year of the Nurse.
Thank you
very much.
Thank you.
Yay! Yay! Oh, Alexandria, I love your mask.
Thanks so much to all your really good.
It helps to have all these smart nurses, you know,
Yeah.
the superstars.
I put a Facebook post up on my Facebook yesterday for the 200 years of Florence Nightingale, and it had 3 pictures and talked about how great the nursing career has been for me. And I've gotten a lot of comments, so yeah. And I really mean it.
Awesome. That's wonderful. I'll share the link as well for registration if you want to share that with any colleagues or friends, or even post on your social media.
Okay. Thanks.
Everyone.
I'll
Thank you
see-
all.
I'll see you down there shortly.
You sure will. We have another project that we're working on. It's called Hand Sanitizers for Nurses. So University of Louisville has been asking and receiving hand sanitizer from the distilleries, and the KNA is buying 5,000 bottles so that we can put that. Yes, that's it. That's it, Dawn. That's it. So we're buying 5,000 bottles so that we can label them and get it rebottled to get it out to nurses across the state, because there's no hand sanitizer in the stores. So that's our next project. KNA has been busy. What can I say?
Good deal. Thank you.
Thank you for all you guys do.
Yeah, thank you too.
Thank you, everyone. Bye.